Thank you so much, Sarah and Rupert, for having me come and join you guys for this talk today. So I'm really excited to share our work with you all. My name is Reine-Marcelle, as Rupert mentioned, and I'm a current third-year medical student at Weill Cornell Medical College in New York. I had the pleasure of working in Dr. Akeju's lab for about 3 years prior to starting medical school, during which I worked as a senior clinical research coordinator and worked on a lot of anesthesia and neurophysiology studies. Today's presentation, as noted, is going to be about ketamine's neuromarkers and dissociation, so mainly how ketamine induces Eeg oscillations that may aid us in understanding anesthetic states, but not necessarily help us with dissociation monitoring. So I just wanted to take a second also to recognize the rest of our team who worked on this study. Now moving on to just some basic history. I'm sure I am sharing this with a bunch of psychiatrists, as I told Rupert, so you guys are all aware. But some history about ketamine. Ketamine is a derivative of phencyclidine, which was initially synthesized in 1956 and deemed to be, although a safe anesthetic, not able to be used in humans for anesthesia because of some significant emergence delirium that was associated with it. They subsequently ended up synthesizing ketamine in 1962 and did the first human anesthetic trial in 1964. The study was conducted by Dr. Edward Domino, who is pictured here, and his colleague, Dr. Gointer-Corson. Then in 1970, ketamine's first product, Ketalar, was approved by the FDA here for clinical human use. Now, it became widely used in the Vietnam War, mainly because the rapid onset of its anesthetic uses allowed for treatment of many injuries on the battlefield, particularly for the treatment of wounded soldiers who needed anesthesia for amputations and other surgical needs. Now, at this point in time, we have started using ketamine mainly in terms of anesthesia and then also for post-operative analgesia. For these two uses, we hypothesize, and most studies have shown in the literature, that the mechanism of action is due to its NMDA receptor antagonism. Through this mechanism, it has been associated to definitely cause anti-hyperalgesia, and then also to end up modulating the need for opioids by modulating and also potentially reversing opioid tolerance. At higher doses, it can be used for general anesthesia and has been associated with something that is called dissociative anesthesia, which is characterized by hypnosis at lower doses and unconsciousness at higher doses, as well as with anti-nociception. Now, from your guys' standpoint, from a psychiatric standpoint, what's been interesting about ketamine is also its use in antidepressant methodologies. We know that in 2000, Berman et al. Published a paper that showed that ketamine was useful in decreasing depressive symptoms for about 72 hours after its administration as compared to placebo. We also saw this confirmed by Zarate et al. In 2006, showing that the decrease in depressive symptoms lasted for occurred within 110 minutes and lasted for up to about a week of ketamine administration. This mechanism of action is definitely distinct, but followed alongside with its anti-suicidal effects, which were shown in Wilkinson et al.'s paper, showing that ketamine ended up showing a rapid decrease in suicidality as deemed by the HAM-D and the MADRS tools within 1 day and up to a week of the administration of ketamine. We also know that ketamine has other receptor targets, mainly from a dopamine standpoint, also monoaminergics and opioid standpoints. At this point in time, from our literature understanding, its dissociative effects have been mainly associated with NMDA, but a paper also showed its use based off of an HCN1 pathway. And this paper was conducted by Oluwaseun et al., where they used a mouse model to show that the blockade of HCN1 channels in mice ended up reducing dissociative behaviors and also showed some more ketamine-associated neuron correlates. Now to share some background on EEGs, because this is an EEG-based study. So mainly when we use EEGs to monitor cognitive states, we end up looking at different wavelengths that are produced on the spectrum. So we look at the Hertz model that ends up identifying theta, delta, alpha, and beta wavelengths, and gamma as well. These are all associated as listed here with different cognitive states, whether theta associated with sleep and memory, or alpha that is associated more with eyes closed wakefulness. Being able to longitudinally see the changes in these wavelengths helps us to understand a little bit better as to what the consciousness level of our patients are and how they're responding to different anesthetics. In terms of current neural correlates for widely used general anesthetics, from our understanding, anesthetics such as propofol at some points in time are associated with coherence in alpha wavelengths across the frontal cortex and also delta and slow wavelengths. Sevoflurane, on the other hand, has different dynamics that rely predominantly on alpha and theta coherence. One thing that has been shown across many different anesthetics is something we call anteriorization, which is the movement of awake alpha wavelengths from an occipital standpoint more to the anterior frontal localization, and seeing that movement and that predominance of alpha is what we look at in terms of interiorization that has been associated with many different general anesthetics. Now, moving on to ketamine. What we do know is that ketamine, as stated before, ends up initiating a dissociative state. In terms of EEG neural markers, ketamine general anesthesia has been associated with decreased alpha and low beta oscillations, which are seen to be within the 8 to 20 hertz power. So seen to be showing that decrease in awake and cognizant and memory processing behaviors that we would have associated with alpha and low beta oscillations. We also show that currently in the literature, a seminal paper by Vasilis et al. Ended up looking at ketamine and establishing some of our current ideas on ketamine and dissociation. They ended up looking at 15 subjects where they characterized a dissociative state and made one of our first key attempts at identifying neural correlates of ketamine, including showing a decrease in alpha power in the occipital and parietal regions. The problem is that neither this study or other studies in the current literature have examined dissociation from a longitudinal standpoint in order to better establish an understanding of causality from the dissociative standpoint. So what we wanted to do was to contribute a little bit more into this question to answer some more as to what we don't know. We currently don't have any known biomarkers for ketamine dissociation. So while we do have those markers as listed for ketamine unconsciousness, for ketamine sedation, we do not know whether or not those markers are associated with the dissociative state. Also, as noted, we currently don't have longitudinal analyses of the ketamine dissociative state and its biomarkers. The reason why this would be important to look at from a clinical significance standpoint is because having a better understanding of this dissociative state would be able to help us better understand other neuropsychiatric disorders, whether that be schizophrenia or panic disorders or OCD that do end up having dissociative states. And it might also help us to be able to better understand the CADS, the clinician administered dissociation state scale, and whether or not neural correlates might be associated with its characterization of dissociation. Going back. So in terms of our study, looking at our hypothesis, we hypothesized that EEG signatures that were associated with ketamine anesthesia may be able to serve as neural markers for dissociation, particularly dissociation as defined by the CADS model longitudinally. We ended up conducting a single site open label EEG study looking at 15 healthy subjects that were healthy as per the American Anesthesiologist Society's physical status 1. We ended up using exclusion criteria, excluding patients and subjects that were pregnant or had family or their own medical history of anesthesia complications, as well as any history of suspected substance use disorders or neuropsychiatric diagnoses. In looking at our study cohort, on average, they ended up being young patients with an equal-ish number of men and women. 8 out of 15 were men, and they averaged at about 24 years old. They all had a BMI of about 23. Now looking at our study design, as stated, we ended up using the CADs to be able to understand and characterize dissociation. This is a previously validated tool for dissociation assessment, which measures perceptual, behavioral, and attentional alterations during dissociation. While the normal scale has 27 items scored, in the literature, a modified version is commonly used for ketamine trials that uses 23 items instead. We also, for our cohort, ended up monitoring the blood pressure, O2 saturation, ventilation, EKG, just to make sure that they had adequate monitoring during the sedative state. We administered a bolus dose of ketamine in order to induce the sedative state. And then we did longitudinal EEG monitoring and CADS assessment during our data collection. Then we administered midazolam in order to kind of cause a reversal of the ketamine effect and to see whether or not it impacted the CADS as well. So looking at a diagram, you can see here that we conducted the first CADS assessment at baseline. After about 2 minutes, we administered the 2 milligrams per kg bolus of ketamine. We waited about 60 minutes while tracking EEG monitoring and did another assessment of the CADS at what we deemed to be a ketamine responsive state. And then we ended up administering midazolam about 5 minutes after that CADS assessment, and then did a CADS assessment immediately after the midazolam administration about 5 minutes later to see what that quick reversal of the midazolam would cause in terms of the CADS assessment. We then waited another 40 minutes to get a post-midazolam score from the CADS. And in being able to see this model helps us be able to define our data based off of 5 different timestamps. Just want to clarify that for us, ketamine unresponsive meant ketamine at the point in time where participants stopped clicking their device, so they became unresponsive. We don't want to necessarily associate this with unconsciousness, as we weren't able to necessarily prove unconsciousness, but this would be more of a sedated state. Meanwhile, ketamine responsiveness refers to patients once they were able to emerge from the ketamine sedation and were able to speak to the clinicians and to conduct a CADS assessment, but they were still in an altered state, which we associate with dissociation. For our data analysis, we ended up using EEG signals recorded by the waveguard system. Our data was averaged from about 3 channels to approximate the frontal and occipital signaling. So the reason why we decided to focus on the frontal and occipital was because of that discussion we had on anteriorization, because we wanted to make sure that our data and results were in the context of previous general anesthesia findings, and previous general anesthesia findings have shown that so many anesthetics show this anteriorization of the alpha from the occipital to the frontal, and shown this dynamic. We wanted to make sure that we were able to capture this with the ketamine if there was any such dynamic to be found. We then used MATLAB Toolbox MathWorks in order to be able to create spectrograms from that data using multi-taper spectral estimates, and use an empirical bootstrap approach to be able to make statistical inferences on the spectral power. In terms of our data, only 4 amounts of data ended up being excluded due to artifacts. So for one subject, we ended up having to exclude data during the ketamine unresponsive state because of artifacts. And then later, 3 subjects' data during the post-midazolam state, their data also had to be excluded because of artifacts. Now looking at our figure 1 of our table, this is when we start explaining a little bit more as to the EEG. So if you look at this, this is our general spectrogram. This is the way that we end up visualizing EEG results. If we look here, I'm not sure if you all can see, I don't think you can see my mouse. But if we look at the first image, you can see that the x-axis is looking at time. We particularly chose 2-minute epochs from each of the participants' EEG data just to be representative of our 5 different timestamps. On the y-axis, you can see frequency measured in hertz, which tells us which wavelengths we're looking at. And then you can see these differential colors, which we term as power. Now, power is our understanding of the level of signal at each wavelength at a certain amount of time. So when you look at this bar here for power, you can see that the dark blue is associated with low power. So that means that there's a low amount of signal at that particular wavelength at that time. Meanwhile, a dark red is a high amount of power, so a high amount of signal at that particular length of time. Now, to get a bird's eye view, as I stated, we're looking at 5 different time points, baseline with our first CADS assessment, baseline prior to the ketamine administration. Then we get ketamine unresponsiveness, which is during that 60 minutes after the ketamine administration, the point in time during which patients are unresponsive, unable to click, they're in a sedated state. Then we move on to our ketamine responsive, which is when patients have emerged from that ketamine sedation and are able to correspond with the clinicians and participate in a CADS assessment, but are in what we understand to be a dissociated state. They are in an altered state. Then we have the midazolam reversal period and the post-midazolam reversal period. That would have been about 45 minutes out from the midazolam administration. What we can see in terms of our results in comparing the EEG dynamics at these different standpoints is that we noted that first, comparing the ketamine responsiveness to our midazolam, number 1. So ketamine responsiveness was associated with decreased power between 13.7 to 23 hertz. So that is essentially our beta level wavelength. Midazolam, on the other hand, was associated with decreased power between 3.4 to 12.2 hertz, and increased power between 17 and 50. So that's more associated on the higher end with our gamma wavelengths, and on the lower end, the 3.4 and 12.2 are more associated with our theta and alpha wavelengths. What you can see here in this diagram, we end up like locating this not based off of hertz, but we end up delineating the particular wavelengths that we're looking at when we're showing these dynamics. As you can see with the red, there's a higher level of slow delta and theta activity during the ketamine unresponsiveness, during the ketamine sedation, as compared to the other states. We also see an increase in gamma, but it's particularly the slow delta and theta dynamic, and also particularly the decrease in alpha and beta activity as compared to baseline that you see with ketamine unresponsiveness. Now, when we move to the dissociative state, you see a global decrease in power, a global decrease in activity across the wavelengths. But what's particularly notable is that during the ketamine responsiveness state, we saw a decrease in power, particularly in the alpha and also in the theta and slow delta wavelengths. So those 3 wavelengths, the slow delta, the theta, and the alpha, showed the greatest decrease during our dissociative state as compared to our ketamine sedation state. Now, in terms of when we conducted our midazolam reversal, this caused an increase in power between 4.4 and the 11. As we said, that's showing an increase of power, particularly as compared to the ketamine responsiveness. You're seeing an increase of power in the beta and the gamma wavelengths that you see at the bottom here, with the redness and the green as compared to the blue and the ketamine responsiveness. Then post-midazolam, as you can see, we see a reversal to what we deem to be a little bit more baseline, which is seeing an increase in power in the alpha wavelength area, mainly the 8 to about 11.7. You see a lighter blue there, and then also a decrease in power between 15.6 and 45.4 hertz as compared to midazolam. You see that the midazolam beta and the midazolam gamma go from this bright red to more of a green, and in the gamma go from the green to the darker blue. So that's showing a decrease in activity at those wavelengths. So we can better contextualize this in terms of looking also at a group level. So these are looking at group level estimates from the spectrograms that we can see as compared to the singular epochs that we were able to show in the previous slides. So looking at group level estimates, in the first slides for figure 2A and B, one of the things that I want to key us in onto is the ketamine unresponsiveness as compared to baseline. We can see that as compared to baseline, ketamine sedation was associated with increased power, particularly between the 0.5 and 8.3. Again, that is our delta and our delta and our theta wavelengths, and then also an increase of power more along the lines of our gamma. So that's going to be about 27 hertz and above. You see this curvilinear line that stays above the baseline throughout those two spikes. Then as we move into our sedated range in the next panel in figure 2B, you see an approximation of this blue line for dissociation that matches more alongside with the baseline actually in terms of the dynamics that it's showing as compared to the sedation level. From sedation to this dissociative state, we see a decrease actually in those theta and delta wavelengths, and then also a decrease in that gamma wavelength. That's what happens before the midazolam administration. In panel C and D, we see what happens with the midazolam administration. Midazolam ends up showing us an increase again in the beta and gamma, particularly with the peak in the beta wavelength that we see at about going from about 20 hertz to about 23 hertz. And then we also see that increase in the gamma from about 17 to 50 hertz. So this is from our frontal estimates. The same dynamic ended up being reproduced from an occipital dynamic, as we can see here in these slides. Now, looking at figure 4, one of the things that we wanted to do was just a proof of concept that using the CADS was able to actually estimate, was able to do a good job of estimating and demonstrating dissociative state as per ketamine's administration. So as you can see, looking at our mean measurements of the CADS at baseline, our mean was a 0.2 score. This increased drastically after ketamine administration. During ketamine responsiveness, which is what we associate to be our dissociated state, you see a mean CADS of about 22.1. Right after, when midazolam is given, about 5 minutes later from that state, you see a rapid decrease of the CADS to 14.3 and a continued attenuation of the CAD score to 5.2 about 40 minutes later after the midazolam administration. So again, this is just a proof of concept to show that, yes, number one, midazolam ends up reversing the effects of ketamine in this way. And number two, that CADS is able to show with ketamine, this level is able to do a good job of measuring dissociation under ketamine through these scores. Now, our problem is that we had hoped to show with that correlation, a correlation not only in terms of the CADS being able to show what dissociation might look like with ketamine administration. We were hoping to show that the CADS would also correlate with neural markers using our EEG estimates, and that some neural markers from those EEG estimates might be able to follow that same CADS model. Unfortunately, when we did the correlation analysis between the CADS and the frontal alpha and low beta dynamics, we found no neural correlates of ketamine were able to show we found no neural correlates that were able to be associated with the CADS values in association with their characterization of dissociation. So we found no significant correlations, not only from the frontal alpha power, but also the frontal low beta, the occipital alpha, or the occipital low beta. What our results did elicit was a relationship between the CADS and the ketamine, as we showed before. And this dynamic was mirrored by dynamics previously shown in our Gitlin paper published last year, of which we see this image here. As we can see, this one is showing essentially what overlooking over time, looking at what the CAD score was with administration of ketamine and also the reversal with midazolam. This is showing the same dynamic that we proved in our current paper. As you can see, looking at these individual participant levels, over time, we see this peak in the CAD score after the administration of ketamine. And then with their individual administration of midazolam, we start seeing this, this curve down as the CAD score attenuates with the administration of midazolam and the reversal of the ketamine dissociative effect. So looking at that, we were able to have this correlation between our findings, but again, the neural markers that we had hoped would be associated with this CADS model were unfortunately not shown. In our final model analysis in that paper, we actually found that the only markers that were associated were time after ketamine administration and midazolam. Those were the ones that showed significant impacts on the relationship between CADS and ketamine, as shown by these p-values here on the side of less than 0.001 and then also less than 0.005. But outside of those, unfortunately, we were not able to find any other key markers that were able to predict this model. What is interesting is that more recent work by Oluwaseun et al., which we discussed earlier, has been, although consistent with our findings, have postulated that there might be a deeper brain rhythm at about 1 to 3 hertz in the retrospendial cortex that might actually be a better marker for dissociation. They ended up showing that eliciting this rhythm in the deep structures, but not the superficial cortex, was actually associated with dissociation in an epilepsy patient. So looking at our summary of our findings and also future directions, for us in putting this paper together, ketamine is associated with highly structural neural oscillations. We were able to show that with our EEG findings. And we also showed that ketamine-induced increases in the CAD scores were reduced by midazolam. We've shown that in the previous Gitlin paper and also this paper as well, as shown by our EEG spectra. However, no discrete EEG dynamics were associated with CADS-defined dissociation, as explained. And looking at future directions, one of the things that we would like to explore more is looking at whether or not dissociation-specific neural dynamics may be better identified by looking at deeper brain regions. So in general, just wanted to thank you all for having me here to discuss our work. It's been a pleasure to be able to connect with you, and I'm open for questions as to the paper and the work that we've done. Thank you.
Great, thank you very much indeed, Reina. That's really great, and I'd encourage everybody, as Sarah has done, to post questions in the Q&A. So please do that. There's quite a lot for us to chew over in that work, and thank you for explaining it so clearly and succinctly. That's really appreciated a lot. So perhaps while we're waiting for others to pose their questions, I could just go over a few things that occurred to me. Just to sort of say one thing about why we might want a biomarker of dissociation, so to sort of begin at the beginning, if you like. And you said that, you know, it might help us to understand other psychiatric disorders and the CADS. This is more by way of a comment than a question, so I apologize for starting off with that. But I wonder also whether this might be helpful in determining dosing in a depressive, in the context of people with depression, because one of the things that we sometimes find is that the dose can creep up with successive ketamine administrations, and but people become tolerant to the dissociation. So it might be useful in this context as well as a biomarker. Obviously, our work, the work of most of the people on this call are going to be mainly about psychiatric disorders rather than about anesthesia. So I'd just like to make that point, I suppose. And so we've got some questions from other people now. So the first question, can you comment on the EEG measuring technology and whether it would be possible to acquire that for office use and measurement?
Mm-hmm. So by office, do you mean in terms of like in a psychiatric office?
Yeah, so just in a routine clinical, could you use it in that setting?
Yes. So now what's interesting is that there are definitely different EEG methods that you can use. Some systems are used more from an office setting. The ones that we used were definitely, I think, they definitely require training. And in that way, like it would take some time to be able to invest in them. But in terms of their applicability to the clinical setting, I do see them being useful. I think what's interesting is as we're moving forward with more diverse patients, whether or not they can be as useful as they have been in the past. One of the things that we were challenged by was the fact that a lot of EEGs that are currently used use a lot of glue and gel, and that might not be as helpful when looking at diverse patients. That being said, EEGs are currently used in the OR from an anesthesia standpoint. They're used in sleep studies, and some of them don't need to have these 56, 64 leads. We actually ended up using an EEG more from a polysomnography standpoint, ended up using more 6 leads and being able to pull data from there that helped us infer frontal and occipital dynamics. So we don't need, there's definitely different levels as to the technology, but I do think that there are some versions of it that can be streamlined for clinical use. It's just now moving into the question of, as we are generalizing science and making science more inclusive, how we might be able to adapt this technology to be more representative of patients.
Yeah, so this audience always wants to run before it can walk. And Tiago Gill makes a contribution. He says that BIS would be a good solution for EEG in office. So this is the depth of anesthesia monitoring that's commonly used in the OR that you referred to. Julia Mira says Zito EEG is the one we're planning to incorporate at our clinic. So it'd be great to hear from her perhaps a bit later about exactly what that involves. And she's put a link in the chat. Please don't put things in the chat, put them in the Q&A. Okay, but so just to go back to this. Yeah, we've got a couple of questions here about the retrosplenial cortex rhythm. Do you expect the retrosplenial cortex rhythm will correlate better with the CADS is one question. Another question is, what is known about the afferent inputs to the deep posterior medial retrosplenial cortex, or indeed about thalamic inputs?
Now, unfortunately, I am not an expert from the retrosplenial context, so I would love to learn more about the afferent effects as well. In terms of whether or not it would have a better correlation with the CADS assessment, that's definitely something that we're hoping and hoping to look more into, particularly because of the negative findings of our study. We are now able to see 2 different dynamics. We know that CADS is a good marker and a good measure of dissociation. We also know, and a good measure of ketamine dissociation. We also know that ketamine itself has neuromarkers. So we're still now at this stage where we're trying to link the 2 of those, and having this new Sentinel paper that's looking at this deep waveform and showing that you could actually cause this dissociative state by triggering 1 to 3 hertz rhythm, I think from our standpoint was just really exciting because we wanted to be able to see what future questions and future avenues for our research might entail. So that's something that we are excited to look more into, but we are very hopeful that that might be more representative of the CADs and might correlate better with the CADs than our current more superficial analyses of the wavelengths.
We're not trying to turn you into an expert in retrospendial afferents, but just in case you know the answer to this, are the thalamic inputs very different for retrospendial versus frontal and occipital inputs? I mean, I expect the answer to that.
No, that unfortunately I do not know, but also very interested in learning more.
Okay,
yeah.
well, let's see if anybody's got the answer to that later. I'm going to ask a question that's related to what you've just been talking about, which is how these, the fact that you've got this neural correlate might turn out to be useful in the end, and specifically to ask about the way in which you've analysed this. Now, I'm not an EEG analysis expert, but I understand that there are papers that have looked at the correlation between ketamine and dissociation, between ketamine-induced dissociation and different EEG measures than the ones that the conventional ones that you were using, and that's a measure of complexity. And it seems as if the complexity measures that are used are different between different anesthetics, and that ketamine in particular is different, for example, to propofol, in that at the sub-anesthetic levels, the complexity is actually increased with ketamine, whereas most complexity measures are decreased by conventional general anesthetics. So is this something that the group you were working with were interested in, or did they think that that was just rubbish, or do you have any ideas about that?
So from my standpoint, we discuss more particularly these we look at more discrete wavelength associations. I'm trying to understand, so if you could educate me for a second about complexity measures, that's a term that I have not heard before. Maybe I know it under a different name.
Yeah, I mean, it's I wouldn't claim to be an expert on it either, but sort of measures of entropy, if you like, in the data are another word that's used to describe that.
Yes, so in terms of disorganization that's seen on the EEG. So yes, from that standpoint, I have seen that data also in other studies as well. From our standpoint, we wanted to look at more discrete dynamics that were more organized, particularly because from our previous studies looking at sevoflurane and then also propofol, that tends to be the way that we've conducted our studies, is being able to identify discrete dynamics, so that when you are an anesthesiologist in the OR, you can pick up this particular wavelength, this particular dynamic, and be able to know that this might be the state that you're dealing with. Looking at an entropy measure, looking at this complexity, is, I know, something that we have discussed, but we didn't look at for this particular paper. For this particular paper, we focused more on the discrete dynamics.
Okay, thank you. We've got a question here. So this is a question from Ramesh about pharmacokinetics, really. I think any potential difference in single versus dual compartment agents, e.g. propofol versus midazolam. So I think that's thinking about how the different drugs disperse across the different compartments, I think. Is there anything that you can say about that?
In terms of their mechanism of action, I think that we do primarily, looking at propofol, we do primarily associate that as our sentinel general anesthetic. It's the one that has had the most studies with regards to it. As to how it affects in comparison to midazolam, I personally have not looked at that prior in terms terms of how it affects the different compartments. I'm sorry, I can't speak to that, but yes.
Okay.